Well, welcome everyone to our Buncke Clinic Virtual Visiting Professor Series. Tonight we have the pleasure of re-welcoming Professor Rod Hentz, who really needs no introduction, from Stanford University. Dr. Hentz already lectured to us once on tendon transfers for tetraplegia patients, and we were excited about having him back to discuss tendon transfers even further for lower nerve palsies. Obviously, Dr. Hentz needs no introduction, but I'm just going to summarize a few things from his, oops, sorry, let me go back to our presentation here. There we go. So as we all know, Dr. Hentz was the former chief of plastic surgery at Stanford, and during much of my residency, he was actually my chief, which was great. Also the former head of hand surgery, not only at Stanford, but also the VA. He's a former president of the American Society for Surgery of the Hand, which, as we know, is the premier hand group in the US. He has authored hundreds of peer-reviewed articles, has authored multiple textbooks, many of which I own and I use regularly during residency. And he is really an internationally renowned expert in many fields, including tetraplegia, tendon transfers, brachial plexus surgery, surgery of the peripheral nerve, Dupuytren's correction of the paralytic deformities, as he's going to discuss today. And he's a master anatomist and has had a heavy emphasis in his research on the biomechanics of the hand, and of course many more. Personally, I was actually initially craniofacial bound when I was a resident, and it wasn't until the fourth year rotations on the Stanford Hand Service and the Palo Alto VA that I actually decided to switch into hand surgery, and then my next rotation after that immediately was the Buncke rotation. So Dr. Hentz, you get the credit, or I guess the blame, depending on who you ask, for me switching from craniofacial into hand. Thanks again for being with us. We really appreciate you taking the time to educate all of us. And I'm going to give you control now of the screen so that we can go ahead and get started.
Okay, well, thank you very much. As I said before, that's the best introduction I've had since the moderator of a program was late and I had to introduce myself. So thank you very much. Let's see if I can do this now.
So there is a screen button. If you push that, you should be able to share your desktop with us.
Okay, now I'm going to see if I can get to the right place.
Now, yes, you're in presentation mode, so you can swap the displays. Perfect, excellent. That's
okay.
Great. Thank you so much.
Let me see if I can move a couple of other things off here.
Now, we don't see the GoToMeeting kind of hovering icon on top, but you can minimize that for yourself so that it doesn't interfere with your slides.
Okay, let's see. Oh, there we go. I just moved it off. Okay, perfect. I can see my screen and you can too, apparently. So I'm going to talk about tendon transfers for reconstruction of the paralytic hand. And we could spend days and days on various techniques and operations, but we won't be so comprehensive. We're going to deal with some important concepts, some principles, and then talk about some common problems. And let's see if we can get this to go. So what I'd like to ask, well, let's ask Matt, since I have your name, Matt.
Okay.
Give us a definition of a tendon transfer from a conceptual standpoint, not a, well, you take this and you do this, but conceptually, what are we doing?
You are using the power of a different muscle to serve in a different function.
Okay, I think that's very good. And a way to look at it is we're redeploying an expendable muscle that's under good voluntary control so that it assumes another more important function. And just as you said, this requires that Peter has to pay Paul since we're robbing Peter. And then Peter has to be able to afford the lost. So now we can ask Danny, what's the most common indication for muscle tendon transfers?
So
Danny,
sorry
is
about that.
your mic?
No,
Okay.
I'm sorry. I got temporarily disconnected.
Okay, I'll ask
The
the most common indication. What would you say is the most common indication?
I would say the most common indication would likely be for a tendon transfer would be trauma.
Very good. Have you seen this talk before? No, you're right. It's the restoration of function after a loss of motor units from trauma. And this can be loss of a tendon, loss of a muscle, but more commonly, and we'll focus a lot on loss after nerve injury. Key is establishing the deficit and the deformity. It's more than making the diagnosis, in other words, which nerve is out. So look at these three examples of patients with nerve injuries, 1, 2, and 3, and think in your own mind which nerve is out and which anatomic level. So Matt, which nerve is out in this case?
The radial nerve.
Okay, very good. And what level? Is it a high injury or a low injury?
I'm going to say it's a high injury.
Okay, exactly right. It's a high injury, and we'll talk about why that is in a moment. So now, Danny, which nerve is out here?
That looks to be like somebody who has an ulnar nerve injury.
Okay, very good. That's an ulnar nerve injury. Same question, high or low? This is a harder question to answer, I think.
I suppose that is a high injury.
Okay, it might be a high injury, and we'll talk a little bit about why this actually may be more of a low injury, but we'll get to that in a moment. It's sometimes hard to tell. And finally,
Now, Dr. Hentz, in the interest of fairness, our third fellow, Kate, has also joined. Sorry, Kate, to throw you in the mix, but we'll have Kate also be in the mix here.
Kate has been thrown under the bus, so okay. So Kate, which nerve? So this person's trying to pinch, as you see, he's trying to, and his hand is just kind of, thumb is just lying flat.
I don't see her microphone being on. I don't know if her mic's working or not.
Okay, somebody else want to jump in, Matt or Danny?
Looks like a median nerve injury.
Okay, high or low?
I think it's a low median nerve
And
injury.
why would you say that?
Still able to flex his index finger, and you see the atrophy of the thenar eminence.
Right, you can see that he has flexion at the IP joint of his thumb. So his FDL is likely working, and so that's a median innervated muscle, innervated higher in the forearm, and the same is true of the index finger EIP joint and the profundus tendon. So very good. So other indications are to restore function from loss of motor units secondary to neurologic diseases such as polio, Charcot-Marie tooth disease, syringomyelia. Let's see, is Kate's microphone on? Is Kate's microphone working?
Kate, are you there? I'll text her to see if she can turn her mic on. But in the meantime, we can move on to one of the other guys.
Okay, all right, Danny, what's the diagnosis in this picture?
It looks like he has it looks like he's got a disease called Hansen's disease.
Right, he's got leprosy, or so-called Hansen's disease. Very good. He has the typical facies of Hansen's disease. And the other common nerve injuries, less common though, are things like brachial plexus in adult or obstetrical cases, cervical spinal cord injuries. And also, there is a category of indications for tendon transfers to restore balance, not to restore loss of function, but to restore balance where there is imbalance, such as this presentation, very typical of cerebral palsy. So let's get on to principles. The indications following nerve injury relate to whether it's possible to repair the injured nerve. If it's a spinal cord injury, that's irreparable. If it's not, it's a peripheral nerve. Where is the location of the nerve injury relative to the time for regeneration for the paralyzed muscle? And this relates to the time since injury, somewhat to the importance of the functional loss, and clearly to the available expendable transferable muscles. If we have none, we have no recourse to tendon transfer. So here's our first patient. He's a 40-year-old laborer. He had a mid-forearm laceration 2 years ago. He had a median nerve repair and has regained protective sensation. He comes to you asking what can be done. So, Danny, what key information do you need?
Well, we know that he has had an injury that was several years old, so an acute repair of the nerve would likely not re-give him function. In addition, it looks like he's got some end organ damage. In other words, his musculature looks like it's denervated and atrophied. So the question will be like, what other functions can he spare? And the possibilities would be a tendon transfer to give him back opposition.
Okay, so what you're asking is, well, let's go back. What's the functional loss? We know what's not working here, but what does it mean to him? So which motor functions are important for the patient? Some patients who have no ability to oppose the thumb aren't particularly bothered by that. Mm-hmm. What is the sensory deficit? Because this is a mixed nerve, and we have to remember aberrant innervation because this can fool our examination. So some additional knowledge that you mentioned, what muscles continue to work, what are expendable? And we categorize this, we test this by doing manual muscle testing generally. We can do sophisticated nerve conduction and physiologic studies, but generally we fall back on manual muscle testing and using the British Medical Research Council, the M0 to 5 classification, where M0 is no movement, M1 is a flicker of movement, M2 is movement but not strong enough to resist gravity, M3 means movement against gravity, M4 means you can do some work, you can resist some force, and M5 is a normal strength. So we can do our manual muscle testing and grade the various muscles according to this category. Keep in mind that there is a minimal power that's needed. And why is that? Generally, we need a muscle to be a good M4 or M5 because we expect to lose some power as a consequence of the transfer. And so if you start with an M3 muscle and you lose power, and now it's not even an anti-gravity muscle, you've probably done that patient a disservice because it won't do work, and you may have robbed that person of some important function for no gain. So M4 or M5 before we consider tendon transfer. And then we have to look beyond the injured limb at the patient, the intellectual capacity. Somebody who can't understand directions or not going to be able to follow a therapy regimen is not a good candidate for a complicated series of muscle tendon transfers. With the patient, we have to establish goals and make sure they're realistic. Patient says, I want to be normal. well, that they're not going to be satisfied. So we have to know what their expectations are, and that they're realistic, and that they have the motivation and the time to devote to getting this to work. So let's talk about selecting a muscle for transfer. What's important? There are 5 important parameters. There are many more, but I think these are the important ones to keep in mind. The muscle has to be expendable, and it has to be under good voluntary control. And generally, it has to have always been under good voluntary control to do a really good job. And by that, I mean, we have to be very careful in using a formerly paralyzed muscle for a muscle tendon transfer. The muscle has to have sufficient power, and it has to have sufficient amplitude. And it's certainly ideal if the muscle that we're using has a function that's synergistic for the muscle that we hope to replace. So we've talked about expendability and control. Let's now talk about power. You get extra credit if you can name this Hollywood star. Anybody? Greg Buncke?
Tyrone Power.
Tyrone
Wow.
Power. Greg, extra credit for the boss. Attaboy. Tyrone Power, very good. So there's a lot known about muscles. The sarcomere is the basic active unit of the muscle. And if you measure the distance between these Z lines, you can come up with this so-called length tension diagram. And you can see that the greatest tension is at the R length. And this is generally felt to be the resting length of the muscle. And this is the place where the actin and myosin elements all line up and overlap as great as possible. The farther you move in one direction or another from that R point, the less these units line up and the less power there is in the sarcomere. So if we put together all the sarcomeres into a muscle, we can come up with a tension curve. And this is the curve that was developed by Sir Magnus Blix. And it adds the active contraction of the muscle with its elastic recoil to create this total tension. So you can see that there's the contractile force plus the passive stretch to give you this shaped curve, which still has the peak at the R value, the resting length. Paul Brand took this curve and he subtracted the elastic recoil of opposing muscles, and he came up with this total tension curve, which more accurately reflects the function of the muscle. Fortunately, for most muscles, the relatively normal functional region is fairly broad. And that's really good for the surgeons, because I think we have a hard time in recreating the exact normal resting length of a muscle when we do a muscle tendon transfer. But because the muscle has this capability, we don't have to be 100% accurate to get a very functional result. So we can predict muscle power based upon the cross-sectional area of the muscle. It's hard to measure all of this. So the physiologists have come up with this term, the physiologic cross-section, which is the muscle volume, which is easy to measure. Take the muscle out and drop it in some water and measure its volume. And then the mean fiber length. And this gives this physiologic cross-section. Brand increased our knowledge by coming up with what he called a tension fraction, meaning that rather than measuring every muscle in an arm, he was able to relate the power of a muscle to the sum of all of the muscles in the arm. For example, all of the muscles in the forearm. And so it's a relative strength measurement. And we can use these tension fractions and tension powers as you see here. And these have been all diagrammed. And we'll look at this diagram and think about our first patient who has the lack of opposition, and we've identified that that's important for him and that he would be a good candidate. So we can look at various muscles, and we can see that they're very, very strong muscles, big tension fractions, such as the supinator, flexor carpi ulnaris, pronator teres. But if we look at what's missing, and that's the opponens and the abductor pollicis brevis, we can see that these add up to about 3. And if we start looking around, we can look at the extensor indicis proprius, and we can see that its tension fraction is 1. Flexor carpi ulnaris is working. Its tension fraction is much greater than what we need. We wouldn't want to necessarily use that because that might cause an imbalance. On the other hand, the FDS to the ring finger, an expendable muscle, has a tension fraction that more closely represents what we need. So I think the FCU is too strong, the extensor indicis is too weak based upon Rand's tension fractions, and the FDS to the ring is a better balance. The muscle has to be able to have enough amplitude of excursion to do the job. So we have to consider this. The excursion is proportional to muscle fiber length. And these have been measured for all the muscles in the upper limb. And as a rule of thumb, the finger flexors have about 70 millimeters of excursion, particularly the profundus. The finger extensors about 50 millimeters. The wrist flexors and extensors about 33 millimeters. This brings to mind a question. Frequently, the extensor carpi radialis longus is used as a transfer to substitute for paralyzed finger flexors. The ECRL has an amplitude of 33 millimeters. So how in the world can it substitute for paralyzed finger flexors, which require 70 millimeters? So Matt, any idea how we know it works, so why does it work?
You get the benefit of, with that motion of the tenodesis effect to kind of transmit downstream, so to speak.
That's exactly right. So the transfer has an active contraction of so many millimeters, and then it doesn't do any more. But as the wrist moves, as the intercalary joints move, you get an increase in the amplitude, increase in the effective amplitude versus the actual amplitude. So we take advantage of these intercalated or intercalary intervening joints to improve the function of our tendon transfers. And finally, synergy. Well, synergy means that things work in association with each other. And for example, our finger flexors and our wrist extensors are said to be synergistic, meaning that they work sort of at the spinal cord level. You don't have to think about extending your wrist when you want to make a strong grip. You do it automatically. And the same is true for finger extension and wrist flexion. You can test synergy yourself by moving your wrist into flexion and extension really rapidly, or making a grip and opening it widely really rapidly, and then trying to do the opposite, trying to flex your wrist and flex your fingers quickly, and then extend your wrist and extend your fingers quickly. And you have to think about that, while the other you don't think about at all. So if you can choose a synergistic muscle, it's more easily retrained and likely to be more functional. In terms of the design of transfer, we've learned that simplicity favors a good result. A straight line of pull is the optimum. We can't always have a straight line from the origin of our muscle that we're going to transfer to the insertion of the muscle tendon unit we're restoring. So we may have to put in a pulley, but we would like to minimize the number of pulleys because this reduces the function. Key here is to give your transferred tendon one function, because that's all it'll do. You can't ask a muscle to both very effectively extend the fingers and extend the wrist. It'll do one function and use most of its power and amplitude for that and have little left for the more distal function. So you need to be able to stabilize the joints from your motor, transferred motor, to the new insertion. So you have to have the ability to stabilize these joints if this is going to work. So here's our second patient. He has this industrial injury that you see here. Out his thenar muscles. And so we know that this fellow is going to need some reconstruction. So when do we do it? Generally, tendon transfers are sort of done as the last phase of a big reconstruction. If you have to do soft tissue and bone and these kinds of things, generally the tendon transfer is about the last thing we do. So when do we schedule tendon transfers? What are our thinking? I think the key is to consider stability, both in the patient and the wound. Are the wounds all healed? Are the scars mature and soft? You don't want any scars if possible, and no skin grafts in the path of your transfer if you can help it. The joints need to be supple with as full a range of motion as you can get before considering a transfer, because your transfer is not going to make stiff joints work. You have to have the joints supple in order for the transfer to work. And importantly, the patient has to accept a lower order of performance. It's not going to be as good as the original equipment. We're talking a lot about nerves and nerve injuries and nerve repair. So the guidelines after nerve repair, usually our tendon transfers are performed late after nerve injury and repair. We can consider transfers if we don't see any function in a muscle in the expected reinnervation time. You've done the nerve repair and you've followed the Tinel sign, but the muscles that you were hoping to get reinnervated show no signs of reinnervation, either by your testing or even electrophysiologically. So you can expect that this muscle, even if it eventually gets reinnervated, is not going to do any work. So that would be a time to consider tendon transfer. There are occasional transfers that might be considered very early before the expected reinnervation time. For example, if it provides an internal splint or a temporary substitute, if it can augment if poor reinnervation occurs and replace the function if reinnervation fails. I think one potential category is a high radial nerve injury. For example, after a humerus fracture where the nerve is destroyed and maybe it has to have been grafted with long grafts. And so the expectations go down in terms of function. And for that patient, you might want to consider an early muscle tendon transfer, because if it functions as it should, it gives them temporary good function. And if all the reinnervation fails, it replaces what nerve repair didn't do. So in review, we want to evaluate the patient. We want to identify the reconstructive goals and make sure they're realistic. Catalog the useful motors by muscle testing, being sure they're both expendable and strong. We want to choose the optimal design, in other words, have a plan. Make sure that we've established tissue equilibrium between scar and joint motion. Make sure we've identified all the impediments to success. In other words, for example, if the patient has to go right back to school and can't do any therapy, maybe that patient ought to wait until they can afford the time. Once we've satisfied these, then we can operate. So let's talk about common nerve palsies. So here's our patient. Matt identified this as a radial nerve palsy. it's a high injury, and generally we separate high versus low sort of relative to radial nerve injuries above the elbow and below the elbow, because injuries above the elbow will affect the wrist extensors, and so the patient will get the dropped wrist as you see here, whereas radial nerve injuries distal to the elbow frequently preserve at least the innervation to the extensor carpi radialis longus, so the patient is able to stabilize the wrist. So we want to identify what muscles are paralyzed. Well, in a radial nerve injury, a high one, all the forearm postaxial muscles, wrist extensors, forearm supinators, finger extension, thumb abduction, thumb extension, these are the muscles that are paralyzed. The next question is, what's the functional deficit? For a high palsy, it's the loss of digital extension, which causes difficulty in acquiring objects, and the loss of wrist extension, which impairs powered grip. Even though the finger flexors are all working, if the patient can't stabilize the wrist, then those flexor muscles go down the Blix curve and can't generate full power. For a low palsy, the functional deficits are less extensive and include loss of digital extension, which, as I mentioned, gives difficulty with acquiring objects, and frequently wrist imbalance. So Danny, why does a low palsy result in wrist imbalance?
I believe that's as a result of the loss of the extensor carpi ulnaris.
Very good, exactly. So the ECRL is working in this guy's case, and he can stabilize his wrist, but the ECRL, because of its vector, has a abduction vector at the wrist, a radial deviation, as you see, and there's no balance for that, so his wrist radially deviates. So the reconstructive goals then for a high palsy include wrist extension, and for both high and low palsies, restoring thumb extension and finger extension. So how do we do that? Well, if we go to the literature, we can see that almost every combination of muscles has been attempted over the last 100 years. So what do we choose? How do we choose what we want to do? In talking about wrist extension for a high palsy, the needed function is the key muscle for wrist extension, which is the extensor carpi radialis brevis. That's the most effective of our wrist extensors, and we can see using Brand's work, the resting fiber length and the tension fraction. We can see what's needed, and then we can look at available motors and come up with perhaps the best combination. And so a good substitute based upon the physiology would be the pronator teres. And in fact, this is probably the most commonly performed transfer to restore wrist extension, universally accepted. So we've already sort of answered why insert it into the ECRB and not into the ECRL. And the answer, as was mentioned, is because the ECRL is a radial deviator as well as a wrist extensor, and you don't want radial deviation of the wrist. So we choose the central insertion because it has the greatest moment arm for wrist extension, and that is the ECRB. The other reconstructive goals, thumb extension. Again, if we go back to Brand's work, we can see what the factors are for the extensor pollicis longus, and then we can look around and see what expendable motors most closely fit the bill and consider choosing that, consider why not choose that. And for example, here, the palmaris longus, if it's present, is a pretty good match for the EPL. And so that has been preferred by many, transfer of the palmaris longus to the extensor pollicis longus. And the routing varies from author to author. My favorite routing is to withdraw the tendon of the extensor pollicis longus by dividing it, as you see on the left diagram, withdrawing it at the MP joint of the thumb, and then routing it directly toward the palmaris longus so it has a relatively straight line of pull. And what you achieve is both extension and abduction. So you get some benefit of both of these vectors without necessarily having to do a transfer for thumb abduction. The patient has to accept some bowstringing of this transfer in order to achieve a good result. For finger extension, again, we fall back on brand and we look at the numbers, and we see that we have a number of possible transfers, available motors, FCU, FCR, the FDS. Which ones do we choose? I think the earliest was the flexor carpi ulnaris to the extensor, the common digital extensors to restore digital extension. Others have said that this utilizes one of the prime wrist stabilizers, the FCU, and in a low radial nerve palsy, this may lead to even more unacceptable radial deviation. And so Brand proposed transferring the flexor carpi radialis to the extensor digitorum communis, leaving the FCU in place for its power. I've preferred the FCU transfer for several reasons. One, it's what I saw most often as a resident, and certainly the time I spent as a fellow with Bill Littler. And I saw good results with this procedure and started doing it and continue to do that for most individuals today, except for the person that I think really truly needs FCU function. For example, somebody who's swinging a hammer all day. But here's a patient who's had these 3 transfers, and maybe, I don't know if my arrow will work. You can see that's the palmaris longus to the EPL, and you can see it bowstrings across there. And some people might find that objectionable. My patients don't seem to mind. Let's look at the next nerve, median nerve palsy. Recall that the median nerve is mostly a sensory nerve, at least for the hand. And that's the greatest functional deficit. And so we have to keep that in mind. But in terms of its muscles, in a high median nerve palsy, all the median nerve innervated muscles are paralyzed, and the functional deficit is a weak grip, a weak pinch, and the loss of thumb opposition, as you see in this patient who has a high median palsy. For low palsy, the functional deficits are primarily those of the loss of the intrinsic muscles, thumb opposition, and flexion abduction. The reconstructive goals for high injuries include restoring thumb flexion, index and middle finger flexion for a stable grasp, and opposition. For the low injuries, it's primarily restoring opposition. So for high injuries, we want to improve grip and primarily balanced grip so that the index and middle fingers participate in the grip of larger objects. And so the simplest solution, and the one that's most frequently we fall back on, is to attach the innervated 4th and 5th profundus tendons to the paralyzed index and middle finger profundus tendons, adjusting the balance so that when those innervated profundi contract, all the fingers come into a balanced flexion. Recall that we are not improving strength of grip here, are we? We're not adding a muscle. We're sharing the power of a muscle to additional fingers. So if you have a patient that truly needs improved grip strength, then you need to bring in another muscle, for example, a wrist extensor, and not just do a side-to-side tenodesis. For thumb flexion, the brachioradialis is available, and it's certainly expendable, and it's been commonly used because of its particular tendon and aponeurosis structure in the distal forearm. You need to mobilize its tendon for a good distance so that it has more effective amplitude. Remember that it crosses the elbow, so thumb flexor power is going to depend a lot on the position of the elbow. If the elbow is flexed fully, that muscle is relaxed, and the patient's not going to have nearly as much thumb flexor power as when the elbow is extended. So here's our patient. It's our third patient. He's 2 years post median nerve repair in the mid forearm. He's developed protective sensation, but he'd like to have better function of his hand. So what do we recommend? Well, if we go to literature, we can find that there are lots of recommendations. There is an entire small monograph by an author named Rensselaer. It's about 100 pages, and it's all about opposition transfers. And so you can appreciate that almost every muscle has been used. And that, excuse me, satisfies one of the surgical or treatment axioms, and that is if they all work, if there are lots of operations for the same problem, either they all work or none of them work. And in this case, all of them work. So we can look at various routings of various muscles to replace the lost function. We can use the commits transfer. You can see it's in purple. It has a more direct route. It results in a lot of abduction.
Please turn off your microphones if you're not speaking. Thank you.
Some prefer using Guillaume's canal. Others route the transfer across the palm, as you see here. So we have lots of potential opportunities. The Royal Thompson transfer uses the ring FDS. The pulley is the palmar fascia, and the attachment is into the opponent's muscle. It's a good power match, good potential excursion. It's not available for high palsies, but many people prefer this transfer. And you can see the transfer in this case uses 2 attachment points, one into the opponent's muscle and one into the extensor pollicis longus. The transfer I've preferred and have had the greatest experience with was described by Bunnell and others, and that uses the ring FDS. If it's expendable, which is not in a high palsy, but in a lower palsy, it's expendable. Brand described making a pulley out of a strip of the flexor carpi ulnaris so that the transfer could be redirected in the proper direction, and he attached the muscle into the tendon of the abductor pollicis brevis. My teachers, Bob Jason, Bill Littler, didn't see the need to make that pulley, and so they would pass the transfer. Sorry, let me go back to this. They would pass the transfer under the FCU, deep to the FCU, and then over the FCU across the palm, using the FCU as the pulley. And that's what I've done, not needing this pulley as described by Bunnell. Burkhalter described using the extensor indicis proprius, and the pulley basically is the ulnar side of the wrist. The benefit is that it's a radial motor, so it's very expendable. But as we mentioned earlier, it's a relatively weak transfer. And in my experience, the tendon just reaches. You don't have a lot of play with where you attach your tendon in this transfer. The simplest is described by Hentz, and that's using the palmaris longus extended by a strip of palmar fascia. I think this acts more like an internal splint. It kind of holds the thumb in a better position. Certainly it's low morbidity, and I use it most often in patients with long present carpal tunnel syndrome, where the thenar muscles are wasted. You're going to do a carpal tunnel release, and a little bit longer incision gives you the benefit of the transfer. So as I mentioned, I prefer the FDS to the ring finger. There are many different insertion schemes. This demonstrates passing it first deep to and then across the FCU, and then the transfer more or less parallels the muscle fibers of the abductor pollicis brevis. And for most patients, I will weave the transfer into the tendon of the abductor pollicis brevis. And we can talk a little bit about the nuances of the insertion of this tendon in median nerve palsies if we have a moment. So here's a patient some time after this transfer. You can see the FDS. You can see it's migrated a bit proximal, but it still follows the course of the abductor pollicis brevis, and this patient's showing opposition all the way to the 5th finger, and here comparing opposition with the affected side and the unaffected side. Our final nerve is the ulnar nerve. For a high palsy, the loss is nearly all the intrinsic muscles in the hand, the FCU and the FDP to the ring and small finger, resulting in this claw deformity. We mentioned earlier trying to distinguish high and low palsies. And this can be difficult, but in general, a high knee ulnar nerve palsy, at least initially, won't claw very much because the profundus tendons to the ring and little finger are paralyzed. So you don't have tone on these, and so you don't have that exaggerated posture. If the nerve is repaired and those muscles start to recover, you can see gradually a greater and greater claw deformity as the FDP of the ring and the little gain strength. So it's a subtle finding, but sometimes it's helpful. So for a low ulnar nerve palsy, our functional deficit is the loss of all of the intrinsic muscles, save those operating a little bit of the thumb. And the sensory deficit shouldn't be forgotten. So in an ulnar nerve palsy, we have the inability to cup the hand, so you have a flattened palmar arch. If the FCU is out, you have decreased wrist flexion power. The grip strength is going to be affected by the loss of the profundus muscles. You lose MP flexion. You lose integrated MP and IP flexion because of the loss of the intrinsics and the lumbricals. You have problems with loss of the key pinch or lateral thumb pinch, and problems with stability of the thumb in strong pinch at the IP joint of the thumb. The real deficits, I think, occur here, particularly the inability to stabilize the MP joints when the person tries to extend, resulting in the claw deformity, particularly for the ring and the little finger. And this loss of integrated MP and IP flexion results in an ineffective grasp. So here's the normal grasp contact on you can see the surfaces. Compare this with the contact pattern in an ulnar nerve palsy, where the fingers, flexors work without concert with the MP flexors, so the interphalangeal joints come down too early and they contact the object and prevent this stable grasp as we saw in the previous picture. And the loss of stability for the thumb can lead to weak key pinch and instability at the IP joint of the thumb, the so-called Froment side. When that happens, rather than the broad pulse surface of the thumb contacting the index or middle fingers, it's the thumb tip. So not a stable function. Our reconstructive goals then are to integrate finger flexion and extension. It's more than correcting the claw deformity. We want to be able to have integrated IP and MP flexion. And there are many techniques, too many techniques to choose from for correcting claw deformities. We also want to consider stabilizing and strengthening thumb index lateral pinch, and there are many techniques for this. My preferred technique for ulnar nerve palsy is an old procedure described by Stiles and Bunnell using the FDS to the ring finger split into two tails. They're passed down the lumbrical canal and inserted into the proximal phalanx if the PIP joints can be fully extended when the MP is blocked, meaning that the extrinsic extensors are adequate at the MP and IP joints, and all you need is just to keep the MP joints from hyperextending. In that case, I put them into the bone of the proximal phalanx because it's a sturdier and more secure function. Otherwise, they're transferred into the lateral bands if you need a boost for IP extension. Brand described, particularly for patients with both motor and both median and ulnar nerve intrinsic weakness, transferring the extensor carpi radialis via tendon transfer, a tendon graft, if you will, an interposition graft, as you see here, taking advantage of wrist extension and the tenodesis effect to get a better function, passing this volarly and then the grafts through the carpal tunnel. For key pinch, to improve thumb adduction, I preferred taking another FDS and passing this transfer along the course of the adductor pollicis. So the transfer parallels the adductor pollicis muscle and insert it half into the half into the ulnar collateral ligament and half into the extensor pollicis longus. This technique, which I learned in my tetraplegia work, coming from our colleagues in New Zealand, which we still call the split New Zealand transfer, I've adapted to all my ulnar nerve palsies. And in this case, half of the FPL is detached from the distal phalanx, and it's routed dorsally and put into the extensor pollicis longus at equal tension to the remaining tendon on the flexor side, so that the force of the transfers affect mainly CMC and MP flexion and less IP joint flexion, so that you correct the Froment sign. The fourth transfer that I've come to do routinely for these patients involves using a slip of the index, using the common digital extensor to the index finger, which is detached proximally. It's pulled out distally at the MP joint. It's wrapped around the tendon of the first dorsal interosseous, and then it's passed back proximally, and it's sewn into the extensor carpi radialis longus tendon. Why the extensor carpi radialis? Well, if you put your thumb on your extensor carpi radialis longus and pinch really hard, you can feel the ECRL tendon push up against your thumb, meaning that that tendon turns on when you want to pinch strongly to stabilize the wrist. So this tenodesis effect with this transfer, I think, has improved stability of the index finger against the force of the thumb. So here's a patient that was previously clawing, as you see here, correcting the thumb deformity, as you see here. And this is a lovely result from my colleague Caroline Leclerc after these transfers. As you see, stability of the IP joint of the thumb, minimal clawing, and good coordinated flexion and extension. Okay, Matt, last one. Give me a diagnosis here.
Sorry about that. He is in hyperextension at his MPs. So I think he has, it's probably an ulnar and median nerve injury.
Very good. Exactly. You can see he has MP joint hyperextension of all the digits, and he has this flat palm, as you see here. And you can make out sort of the atrophy of the ulnar muscles. So in combined palsies like median and nerve palsies or brachial plexus, our reconstructive strategies frequently have to change because generally our goal is to provide a helping hand. And for that, we may need to simplify the mechanics of the limb. And this may involve arthrodesing or fusing joints, for example, fusing the wrist, fusing the thumb CMC joint, because we just don't have enough motors to provide stability for all the joints. And so fusions and tenodesis frequently are the strategies that we need to add to muscle tendon transfers. So that's all I have. Brains are full, so I'll stop there and be happy to answer questions. We have a couple of minutes left.
Great. Thank you so much, Dr. Hentz. Always great to hear your experience in these very actually common problems, which I think every hand surgeon should be very familiar with. I have a few questions that I'll start with, and we'll see if anyone has any questions in the comment section. With regards to radial, oh, you want to turn that off? Here, I'll let me actually do that for you.
Okay.
Oops, sorry, not that one. There we go. All right, now I'll turn my camera back on.
Very good.
Okay, great. So for a radial nerve palsy case, in a case where you may not have the palmaris longus available, obviously there's a case where you'd be incredibly lucky and somehow the BR is preserved, which is rarely ever the case. Is your preference between the options of doing a mass weave of the FCU or FCR into the finger and thumb extensor versus some have described a split FCR, which it seems like you're taking too many flexors of the wrist if you do that. What are your preferences in that case?
If they don't have a palmaris longus, what I've done is to put the EPL in with the EDCs and done an ECU transfer. And then I've taken the abductor pollicis longus tendon, at least one strong slip, and I have fiddled with it, taking it out of the first dorsal compartment and passed it first down one tunnel and down another tunnel. And I've put it inside under a lot of tension into the flexor carpi radialis. So it acts kind of like a dynamic tenodesis, if you will. It works reasonably well, not great, but I've been loath to transfer, for example, the brachioradialis because it's such a strong muscle and you worry about creating an imbalance with a very powerful muscle substituting for what really is a positional muscle.
Yep. Thank you for that. It looks like Professor Balakrishnan from Chennai, India has a question. Professor?
Hello.
Yeah. Professor Hentz, it was an excellent lecture. Have you ever tried intrinsic activation? Especially for South Indians, they used to grab the food by holding the hands. So what we do now, take the flexor digitorum sublimis of the middle or ring finger depending upon the power, and then we go and insert into the interossei muscles. We take 5 slips. One is to the abductor of the index, the other is from the abductor of the digital little finger. The other slips will go into the interossei muscles, 3 slips, so that we have a good coupling of the hand and all of them will work together so that you can go and grasp the rise from the plate, so that you'll be able to just do like this and then try to get the food and hit your mouth. Have you tried that intrinsic described by Dr. Palade from South India?
I've not tried that. Thank you. I've not tried that particular transfer, but I certainly see the benefit in restoring the cup.
Cupping of the hand, yeah.
Yeah, and I think that's an excellent choice. Thank you.
Thank you, Dr. Bala, for that question and comments. Dr. Hentz, I have a couple of other questions. One of them is regarding the brand transfer. I did a couple of them during residency with you, and obviously, as we know, there's the brand 1 and the brand 2, and the brand 2 is the one that I did with you in residency, where the wrist extensor is routed volarly proximal to the wrist, and then the tendon grafts are attached and then taken into the lateral bands usually. The brand 1 crosses it at the mid hand from the intermetacarpal spaces. What's your opinion on the biomechanical differences between those two? It appears that the brand 2 potentially has an advantage from a biomechanical standpoint, going from volar to dorsal in a more kind of a natural vector.
I agree, and I think Brand himself said that. That's why there was a brand 2, because he said, looked at the mechanics and he said, well, maybe routing it this way, I can take advantage of the wrist a little more and have a better transfer, a more adaptable transfer. I've also if you're bringing your transfers down through the interosseous spaces in the hand, I worry a little bit about adhesions in that area. There's a whole lot of space on the flexor side with a lot of fat and not much on the extensor side.
Got it. That makes a lot of sense. The last question that I had for myself, at least, for our opponents' plasters, or opposition transfers rather, the most common indication in our practice, just being where we are, is usually an injury beyond just a median nerve laceration. It tends to be a complex spaghetti wrist or a complex forearm injury where the FDSs were also injured and they were repaired. So in our practice, we tend to do a lot of EIP or the Burkhalter transfer. I was wondering if you've had any experience transferring a previously repaired FDS4, assuming you've gone in and you've done a tenolysis and you're freed it up. Have you ever done that in a setting of a spaghetti wrist?
Yes, yeah, I've used previously repaired tendons with the expectation they're probably not going to function as well as an uninjured tendon, but it seems to have reasonable excursion, and particularly if it's independent, then I'll use it. I don't know, I'm a little well, it depends. I think today with better, at least theoretical means to attach tendon to tendon, strong enough so that you can do really early motion, early like the next day, it may be reasonable to do a tendolysis and a transfer if you can expect that you can move that transfer the next day. I think if you have to do a tendolysis and then hold the transfer still for 3 weeks, then that's probably not going to work so well.
That makes a lot of sense. Any questions from the audience? Greg, are you on either comments or question?
Yeah, I'm here. Professor Hentz, thank you again for making it so clear to us, these ideas. I have a question about your ideas of inserting the FDS in an ulnar nerve transfer for claw deformity. I've always put the transfers into the lateral bands and have never put the transfer into bone. Is there a disadvantage to doing a transfer of the FDS into the lateral bands versus into the proximal phalanx?
I don't think there is necessarily a disadvantage. Most, tendons generally attach to bone, and so as a concept, I've liked that. And so if I don't need an extra boost for IP extension, it's been just my concept is that I can get a stronger attachment by putting it into bone. You can do a screw anchor or interference type screws or drill holes through bones, and it just I had more confidence that the tension that I set, I was going to maintain.
I see. And then what about lassoing into the distal portion of the A2 pulley? Are you doing that much?
We do that a lot in our spinal cord patients and our tetraplegic patients to try to restore some intrinsic balance for them. And I think it's it certainly is a reasonable thing. I think you need to go out into the A2 pulley area a bit if you really want to get an effect from that. But it's it certainly is a reasonable thing to do. I think if you're doing multiple fingers, it's technically easier to put it into lateral bands because you don't have to go monkey around with the the profundus tendon and the pulleys and all these kinds of things. So I've, like you, have preferred to either put it into the bone or into the lateral bands.
Got it. Thank you.
It looks like Danny actually has a question for you this time. Danny?
It's your turn, Dr. Hentz.
Got to be a 50-50 question. Go.
Uh-oh. My question is about the tension with which you place on your transfers. I understood something from your talk today that makes a lot more sense in my mind now, and that you showed a curve in which there is this broad range of lengths through which the muscle has good tension and therefore appropriate sort of myosin and actin overlap where you get good force. My question for you is, when you tension your transfers, how tight is appropriate? And can we apply that concept in when we transplant muscles for functional deficits? For instance, when we do a functional transfer for, biceps function, or even a muscle transfer for facial reanimation. I know that there's always a lot of thought about how much stretch you put on the sarcomeres. I wanted to know what your thoughts are about, what you've learned.
So your question is, how do you tension a transfer? How do you know
yes,
it's appropriate? And my answer has always been, you do it just right. And so just right requires some experience. I think that we have an advantage in our own hands because we have our hand that's normal, and we can go through some motions. We can extend the wrist and flex the wrist, and we can see that our transfer has achieved the kind of balance that we'd like when we flex the wrist and extend the wrist if we're trying to innervate something out more distal. So that's been very helpful. There are situations where it seems wise to pull it tighter than you think, sort of as tight as you can without things rupturing. For example, pronator teres to ECRB. I think the admonition is to put that in really tight because that's one muscle having to work against about 12 muscles on the other side. So it's really no contest. And so I think you want to create some stiffness, and that's what you'll get if you over tension the transfer. The muscle will become a little stiff. For free muscle transfers, the admonition from Ralph Manklow and the pioneers was to place little markers
to measure it. Yeah,
to measure the muscle before you detach it and then try to recreate that. I did that, and I could never ever pull it tight enough to get the markers to go where they were. Maybe I wasn't. Maybe I was too afraid, but I'd pull hard and I'd pull hard, and I could never get that thing 5 centimeters apart. It always seemed to be too tight and way too tight. But I think you can also use, if you're trying to restore finger flexion or thumb flexion, you can use the tenodesis action of the wrist to kind of help you achieve the right kind of balance.
Thank you.
Well, Dr. Hentz, it's really a pleasure to have you. You've been a mentor to all of us during our residency, and you continue to teach us even many, many years out. So thank you so much for taking the time to join us today for another fantastic lecture. I hope to hopefully see you in person soon over the next few months, if possible.
Babak, thank you for getting me out of the garden. I'm just so tired of gardening. So thank you.
Excellent. Thanks again. Have a great night.
Thank you. Thank you, everyone.
Okay, bye.